Hello guys, welcome to our channel. Today we are going to discuss the part 2 of the pathology. In this part 2 of the pathology, we will be discussing the important tables and general pathology. Okay, so from the general pathology, we all know that we already done with the general pathology of the mostly the cellular pathology, and then we also discussed about the acute inflammation and the chronic inflammation, then neoplasia and also immunology. Okay, so mostly other topics we are going to cover. If possible, we are going to cover the genetics in this topics. Okay. So whenever I say the important topics such as from the neoplasia, you have to know about the oncogenes and also about the tumor suppressor genes and cell tumor markers and what are the carcinogens. These are the important tables that you have to revise. And in the part 1, this has been already discussed. So those who are new to this channel, please do subscribe and also watch the all the other videos. Next, start with the genetics. In the genetics, we have to make sure that we have to know about the important types of the genetic disorders and their patterns and what are the examples of those particular condition. So there are the two types, non-classical Mendelian pattern and other one is a classical Mendelian pattern, right? Pedigree analysis, that is a classical Mendelian pattern. So in the non-classical, we are going to discuss about the genomic imprinting. This genomic imprinting is about the deletion of the particular chromosomes, such as it could be maternal or it could be paternal chromosome. So if it is a maternal deletion, for example, this is the maternal, this is the paternal. So what happens whenever there is a deletion of the particular, it could be mother or it could be father. So what happens, this has to be duplicated. Okay, this has to be duplicated. So if mother is absent, then the father will duplicate the other. If the father is absent, then the mother will duplicate. So this is what happens in the genomic imprinting. So such as maternal deletion, so it is a paternal duplication. Paternal deletion, then it is a maternal duplication. What are the examples? Angelman syndrome for the maternal deletion and Prader-Willi. P for paternal, P for Prader-Willi for the paternal deletion, and the gene that is involved is the SNP gene, and here it is a UB3A gene. And these patients, mostly these patients are fully obese and they also have the associated hyperphagia. Okay, hyperphagia and leptin. This leptin is deficient in this patient, right? Next, coming to the Angelman syndrome, these patients are like happy puppies. Okay, always look at their face. They are happy always. And most commonly, the both will share the one characteristic, that is the mental retardation. Next, mitochondrial inheritance. Mitochondrial inheritance, it is caused by the genetic mutation in the mitochondrial DNA, and this is only transmitted through the mothers. Okay, so mother can transmit to his son, mother can transmit to his daughter, but the transfer is only from the mother. Here you can see the mother is transmitting to all the children, and then the father again the next generation, this father is not transmitting, but again next generation mother is transmitting, so such that so mother will share it to all, and next the mother generations, that like they're going to share. And what are the examples? Remember the Carey Sear syndrome, Leber's hepatic neuropathy, and Melas Narp syndrome, ophthalmoplegia, Pearson syndrome. Melas is the most common type. Okay, this question has been asked and with the examples and also with the pedigree chart. Next, trinucleotide repeat mutations. What are the trinucleotide repeat mutations? Such as the examples, if it is a CAG, Huntington's chorea, and if it is a CAG, another type, that is a spinocerebellar ataxia, and CGG, Fragile X syndrome, and Friedreich's ataxia is the GAA. And I want to tell about the Fragile X syndrome. Fragile X syndrome, the patient will be having the tall ears, and most characteristic that the patient will be having the macroorchidism and mental retardation. This is the second most common for the mental retardation, followed by the Down syndrome. And the repeats are CGG, classical Mendelian patterns on their pedigree charts. So you have to understand this autosomal dominant And autosomal dominant is that you have to understand these patients are having the 50% chance for each individual. Okay, so here you can see they having here total how many children, guys? One, two, three, four. Okay, so if you can observe, this generation is involved and almost more than 50% that the triads are passed here. And let's see the next generation. And here also they have the three children and more than 50%. And even the next generation, 50% is involved. So that you have to understand autosomal dominant is present in the first generation, second generation, third generation. All the generations are involved. So there is no skipping and incomplete penetrance. Even though if it is a 50%, but incomplete penetrance, that means symptoms, it can be mild or it could be severe. Variable expressivity is seen in this patient. This is the autosomal dominant. When it is comes to the autosomal recessive, this is most commonly seen in India. Why this is most commonly seen in India, guys? Because this is associated with the consanguineous families, like within the relationships, like uncle or the who is the cousin relations, those who are married. This is very common with the consanguineous families in the India. Okay, overall the most common is autosomal dominant only because it has a 50% penetrance. But among the consanguineous families, this is the most common in the India, and they are not associated with the most commonly they are associated with the only one generation. For example, this mother is a carrier, so this mother is a carrier, but this father doesn't have the disease, so most likely the next generation is less likely to get. If the mother is carrier, father is deceased, then the next generation will have the high risk of transmittance of this particular disorder. So commonly more severe than the dominant type because it can cause the carrier stage and also it can penetrate more highly. Here it is incomplete, but it could be complete penetrance is seen here. X-linked dominant. X-linked dominant, again here there is no skipping of the generations. Mostly daughters are affected by the fathers. Here you can see the father transmitting the daughters, and next generation also father is going to transmit to the daughters. This is most commonly seen in the X-linked dominant. Next, X-linked recessive. What happens in the X-linked recessive? This is commonly more severe in the males because females are usually homozygous and carriers. They will transmit to their sons. What is the difference between the X-linked recessive and the mitochondrial inheritance? The X-linked recessive, the female mother is going to transmit to their sons. But mitochondrial inheritance, it could be daughter, it could be son. That is the difference. And what are the examples? Autosomal dominant examples are dystrophia myotonia, osteogenesis imperfecta, neurofibromatous, tuberous sclerosis, hereditary spherocytosis, achondroplasia, von Willebrand disease, Ehlers-Danlos syndrome, and adult PCKD, intermittent porphyria, and Marfan syndrome. The most common is the Marfan syndrome. Autosomal recessive, this is mostly the enzyme defects such as alkoptinuria, beta and alpha thalassemia, cystic fibrosis, deafness, emphysema, Friedreich's ataxia, Gaucher's disease, and homocystinuria. X-linked dominant, these are the Fragile X syndrome, Charcot-Marie tooth thief, and Alport syndrome, Rickets, and Rett syndrome. Rett syndrome is associated with the MECP2 gene mutation. X-linked recessive such as agammaglobulinemia and chronic granulomatous disease, Fragile X syndrome, and Duchenne muscular dystrophy, and G6PD deficiency, hemophilia A and B, color blindness, and the Viscotalde syndrome. All the examples have been asked previously in the examinations. Next, coming to the hematology section, RBC disorders. In the RBC disorders, let's see what is this type of the cells that is present in the peripheral blood smear and what is the defects. So thalassemia, there are two different types. It could be associated with the alpha chain or associated with the beta chain. So the patient will be having the increased RBC count and increased different types of the, rather than the adult type of the hemoglobin, there will be having the fetal type or the alpha type or the beta gamma. There will be other types of the which will be seen, and abnormal electrophoresis will be seen, and these abnormal electrophoresis will be the gold standard test for this patient. And thalassemia cells that you are going to see this kind of, the target cells that you're going to see on the peripheral blood smear. And beta thalassemia major, that is associated with the fetal hemoglobin, and the lead poisoning, which will be associated with the blood test. And lead poisoning, this is going to block the allard dehydrogenase, and also ferric steps. These two steps are blocked by the lead poison. And on the peripheral blood smear, here you can see this, like the basophilic stiffling will be seen around the RBC. Okay, this is commonly seen with the lead poisoning. And when you check urine levels, it is going to associate with the free erythrocyte porphyrin levels are high. Next, megaloblastic anemia, mostly associated with the vegans. And on the labs, there will be increased homocysteine levels and also methyl malaconic levels also seen. And on the peripheral blood smear, here you can see the multiple joint cells and ovalocytes. The macro-ovalocytes will be seen, and hypersegmented neutrophils and basophilic stippling will be also seen in this patient. If it is associated with the folate deficiency, it will cause the neural tubal defects. So we have to give the prophylaxis for this pregnant woman. There will be increased homocysteine, but normal methyl malanoic acid levels will be normal. That is the main difference between these two conditions. Same, there will be Howell Jolly Borders, hypersegmented neutrophils, all will be seen in the both conditions. Aplastic anemia, pancytopenia, hypercellular marrow. Here you can see the marrow. This is completely fat. Okay, this is the bone marrow aspiration, and where you are seeing completely fat only. There are no proliferation of the cells. And hypocellular and dry tab will be seen in this patient. Hemolytic anemia extravascular. So there will be spirocytes will be seen completely like this. The spirocytes will be seen. And hemolytic anemia intravascular, then there will be decreased haptoglobin levels. This is the common feature that is going to associate a decreased haptoglobin. Cystocytes will be seen. G6PD deficiency, there you are going to see increased retic counts. What is the stain that we are using here? This is the supravital stain, only associated and seen for the reticulocytes. And bite cells, Hen's bodies, here you can see these are the bite cells, and this is the Hen's bodies that is seen. And hereditary spirocytosis, if it is a spirocytosis, the most common effect is the ankyrin. If it is a severe one, this is the spectrin. Okay, Coombs text is negative for this patient, and here you can see this is how the spirocytes will be seen. Next, autoimmune hemolytic anemia, which is associated with a worm. If it is a worm, it is associated with a IgG. If it is a cold, IgM. Their Coombs test will be positive in the autoimmune types. Here also you are going to see the spirocytes. Sickle cell disease. What is the sickle cell disease, guys? It is going to be the glutamine, which will be replaced with the valine. Okay, glutamine is replaced with the valine at sixth position. Right, electrophoresis is the best test, and here you are going to see this kind of sickle cells due to decreased oxygen levels. Microangiopathic hemolytic anemia associated with the cystocytes and the helmet cells. Paroxysmal nocturnal glomerular flow cytometry is the best test. What is the defect here? CD55 and the CD59 is abnormal, and this is associated with the thrombosis. Okay, this is associated with the thrombosis pancytopenia. Next, what is the iron profile? How to differentiate? Just remember that one, iron deficiency anemia. Iron deficiency as anemia is decreased with the iron, ferritin levels, and T percentage. And TIBC levels will be increased. And completely opposite to the iron deficiency anemia is the sideroblastic anemia. Okay, here you can see iron is increased, ferritin is increased, TIBC is decreased, and T percentage levels also increased. And anemia chronic disease, this is less likely asked the question. What is the main differences is that here the ferritin levels will be increased. Menzer index is important to differentiate between the thalassemia and the iron deficiency anemia. If it is less than 30, thalassemia. Less. If it is less than 30, it is thalassemia. Iron deficiency anemia is more than 30. Next, WBC disorders. we have to differentiate myeloid types and the lymphoid types. Acute myeloid leukemia. This is seen in the adults, and whereas ALL is seen in the children. And myeloid is positive for the myeloid peroxidase, and all bodies are seen. And the cytogenetics, such as these are also important points, such as the T1517 translocation is associated in the AML, and AML is worst prognosis. Whereas ALL, there are many types, and children are the most commonly affected, and there will be positive of the T12 with the T21, which is associated with a good prognosis and better prognosis in the children. And AML, if it is less than 3 years, then AML M7 is associated in the Down syndrome patient. All right, next. CML versus CLL. CML is in the middle-aged patients, and BCR-ABL, this is the Philadelphia chromosome that is positive here, and mostly these patients will be having the increased WBC levels in all the myeloid stages, and blast crisis, which we can convert back to the AML and the ALL. What is the therapy that you are going to give? Imatinib is the drug of the choice. Next, CLL, which will be associated the SMUT cells, CD5, CD20, and B cells positive, and Richard's transformation, which can convert to the lymphoma also. This is also associated with the high risk with the increased risk for the DLBCL association. Next, Hodgkin lymphoma and their types. Hodgkin lymphoma, they are the types of the most common in the India. This is the MCHL, and the most common worldwide is the nodulosclerosis type of the Hodgkin lymphoma. And what is the important thing here? The most important form is the EBV. EBV means Epstein-Barr virus, that is associated with the MCHL and LRHL and the LPHL, not associated with the NLPHL and the NSHL. Next, Redstone bug cells. The most commonly popcorn type seen in the NLPHL, and the mononuclear type is in the India most common, that is the MCHL, and the classical type is in the LRHL. Non-Hodgkin lymphoma, this is associated here, the image you can see, that is a marginal lymphoma associated with the translocation 11 and 18, and mantle zone is associated with 11 and 14, and germinal is a 14 and 18. All these non-Hodgkin lymphomas mostly see, if you observe, that will be 14, 18, that will be commonly seen. Burkitt's lymphoma, this is associated with the NMIG, right? Sorry, this is associated with the CMIG. Okay, CMIG. And Burkitt's lymphoma, next we are coming here only. So the Burkitt's lymphoma, c-MYC gene mutation, translocation 8 and 2, 8 and 22, 8 and 40. Next, star appearance. Here you can see this is the star appearances without the macrophages and the tumor cells. Multiple myeloma. This is the most common plasma disorder. Okay, what kind of the plasma disorder it can be? Any immunoglobulins that will be present in these patients. And the translocations are 4 and 14, 11 and 14, 14 and 16. Okay, next, the mutation which will be going to cause Rolexi formation. Here you can see this is the Rolexi formation, and deposition of the M proteins will be seen like this. And this patient, the most commonly, how they are going to present? They are going to present with the crab features. Okay, crab features, and the blast cells are more than 30%. This will be the diagnosis. Crab, in that you have to remember there will be increased calcium, but normal ALK levels. Okay, this is the difference from all the bone disorders. Increased calcium and normal ALK levels, and associated with the pain. Okay, this is the common presentation of the multiple myeloma. And on the urine protein, you are going to see the Bence-Jones proteins when it is heated, and serum electrophoresis, you are going to see the M spikes, elevated calcium, beta 2 microglobulin levels are positive, and on the X-ray, MRI, CT scan, you are going to see the punched out lytic lesions. Lung cancers, squamous cell carcinoma, adenocarcinoma, and the small cell carcinoma. These both are associated with the smokers, and most commonly males. Adenocarcinoma, non-smokers, females are most common. And squamous cell carcinoma, central and most common cause overall with the smoking, P53 mutation, hypercalcemia as a paraneoplastic syndrome. And on the biopsy, you are going to see this keratin pulse. Next, this is the positive for the immunochemistry for the cytokeratin P40 and the P63. Adenocarcinoma, that is migratory thrombophlebitis. This is the most common PNS, and TTF and the napsin is positive, and lepidic pattern like this. Lepidic pattern you are going to see. And small cell carcinoma, this is centrally located and strongly associated with the smokers, and LMIC genes CH3P deletions are associated. SIDH is the most common one for the paraneoplastic syndrome. Chromogranin, synaptocyanin, and bombesin, these are the neuropathological positivities and worst prognosis associated, and also body deposits will be seen here. Next, myocardial infarction, the most common enzymes that is to be raised, that is the ischemic albumin and heart fatty acid and also myoglobin. These are the early one. The most common is the first one is the ischemic albumin, then heart fatty acid, myoglobin. These are the early, and other than that, CPKMB and the troponin for the first. And these both are associated for the reinfraction also. Okay, and the long term is 7 days for the stroke point. That's why this is the most sensitive marker. Okay, most sensitive and specific marker. Reinfraction can be done early seen and also for the 7 to 10 days. Ischemia modified albumin for the first one, and myoglobin is the early within the 2 hours. CPKMB is for the 24 hours. And here we also have to emphasize that there is a LDH flip. What is meant by this LDH flip? For example, we have the in the heart we have the LDH1, and in the blood vessels we have the LDH2. So what happens whenever there is a myocardial infarction, these LDH level 2s will be decreased and LDH1 will be increased due to this leakage into the circulation. This is called as the LDH flip. And morphology, on the gross morphology you cannot see less than 32 minutes, you cannot see anything, and after 32 minutes you are going to see the amorphous densities. This is the sign of the necrosis and waviness of the myofibrils. And 1 to 3 days red infarct will be seen, increased neutrophils and the coagulative necrosis. 3 to 7 days there will be increased lymphocytes and the macrophages, and this phase, this is highly associated with the rupture of the wall. Okay, this is highly associated with the rupture of the wall. Day 7 to 14, granulation tissue is formed. Day 28 beyond, there will be complete scar completion. These are the some of the important topics that you have to take note, and remaining pathological systemic subjects will be discussed along with the medicine. So stay tuned, and those who are new to this channel, please do subscribe and share with your friends.